This is a video demonstrating the performance of median arcuate ligament release. The pars flaccida is opened, the stomach is elevated, and the left gastric vein and artery are exposed. The left gastric vein and artery are then separated from the pancreas. The left gastric vein is then dissected away from the artery. In this case, the left gastric vein appeared to be crossing at the base of the left gastric artery. This necessitated the ligation and ligation of the left gastric vein in order to gain exposure of the base of the left gastric artery. As can be seen here, the node overlying the common hepatic artery is removed. This then helps define the confluence of the left gastric artery and the common hepatic artery to expose the celiac artery. The left gastric vein is ligated to facilitate this. The left gastric artery is then dissected and a loop is placed around it. The aorta is then exposed by splitting the crura. Care is taken not to disturb the phrenoesophageal membrane or the esophageal attachments and the anti-reflux barriers that are present. As can be seen, slow, meticulous dissection of the crura overlying the celiac artery and the aorta is performed using a harmonic scalpel. Care must be taken as there could be phrenic artery branches which could be potentially avulsed. In this case, there was a phrenic artery branch which was avulsed and had to be controlled using pressure and clips. The dissection is then carried further superior to expose the aorta in order to give us a target to reach from the celiac artery. Back and forth dissection of the crural fibers overlying the celiac and the aorta is performed. An extensive neurolysis of the celiac plexus is performed, as can be seen here. The arterial bleed is controlled with compression and then some clips. We believe this is from a small inferior phrenic artery branch. An extensive neurolysis is an essential part of this operation. Disease is thought to be mediated more by neural fibers rather than it being a purely vascular inflow issue. Thereby, a meticulous dissection of all these nerve fibers around the celiac artery is essential to perform this surgery well. Dissection is further carried and using the robotic hook, all these fibers are taken down. As can be seen in this clip, the median arcuate ligament is well visualized. This is an extremely tough structure that even with the robotic system, it's evident the amount of force that's required to divide this band. Once this is released, the celiac artery is well visualized, taking off from the aorta. The robotic system in our institute has replaced the laparoscopic approach as the better visualization and articulated instruments offer a far superior operative ability on these complex patients.